Welcome everyone this afternoon. My name is Emilia Andersson. I'm an employee of Roche and I'm a proud sponsor of this exercise. So hopefully many of you attended the introduction and the educational session on BRAF 2 weeks ago and had the opportunity to score cases. And now we will have the opportunity to review the results and discuss the scoring challenges. So with that, I give it to Corrado and Adelina.
Thank you, Emilia.
Thank you.
Thank you to everybody that scored the cases and participated to this circulation. I think this is the most exciting antibody in my lifetime. I think it's so unbelievable to be able to see a mutation with your microscope. It's incredible. I hope that these cases were not too difficult. I don't think they were difficult, but I think they present some challenges that it would be good to discuss. That's the kind of slides of the circulation. And the first slide was case 006, and you can see here the usual breakdown in what the participants have thought about it. And the category was whether we think the mutation is absent or the mutation is present, or whether not so sure, and maybe we require some reflex testing for some reason. And at the bottom, there is a panel diagnosis, which again may or may not mean very much. So for this particular case, the panel thought that the whole of the panel thought that there was no mutation, and about 50% of the participants agree with this view. 25% thought there was a mutation, and about 20% that there was no mutation. So we could review this case. Adelina knows which one it is, and she can drive this one here.
I think it's 6. It's number 6.
Very good. So hopefully you'll be able to see my slides. Yeah.
I think it's turned upside down.
Okay.
So this looks like a skin excision.
Yeah.
And we can see already a low power, the pigment. So we guess is a nodular melanoma, really.
Yeah, or a Spitz tumor. Who knows?
Yeah. It's kind of exuberant.
So the context is important because, as we discussed in the educational session 2 weeks ago, BRAF in skin for melanocytic lesion has got 2 possible contexts. One context is I really need to know about therapy selection, and obviously presence of BRAF mutation points towards use of tyrosine kinase inhibitors, perhaps in combination with MEK inhibitors. And then the other side of this in skin pathology is I'm not so sure about the diagnosis, and I want to understand whether this is a lesion with BRAF mutation or not, because it will help me determine what kind of call I make diagnostically. Okay.
And that's probably best done in a panel.
And obviously, yeah.
As we know. I think in this case, we have very ugly looking cells.
Looks very wild.
Cherry nucleolide, the typical change we see in melanoma.
Yes, and most importantly, actually, when you look at this high power, you realize that within this spread of tumor cells, there are cells that don't really look similar to each other. And that's a kind of a clue, perhaps, towards the fact that this is what we're looking at is a spitzoid melanoma rather than a Spitz tumor, aggressive or not aggressive as it may be.
I was trying to see mitosis, but yeah.
Yes, again, mitosis is the holy grail of pathologists because we want to see written in the section something that tells us the diagnosis. This is not, there is no micro imprint here. Mitosis, maybe.
We like to have all the criteria.
Yeah. But you see here, look, kind of interesting. I know this is not a histopathology teaching session, but you see here how different this cell is from these other cells. So the fact that there are all these different elements, this is Professor Mims, I keep telling you these things, Professor Mims' sign, they say what is considered pleomorphic. Pleomorphism is for melanoma. Okay, so that's very nice. Shall we look at the BRAF, which is this one here, I guess. Fantastic. So you know, in our slide, there is always the control. This may not be a melanocytic control. This is probably a colorectal cancer control. I don't know. That's positive. It shows you what kind of staining intensity you should expect, and nice to see cells that don't stain, so that it gives you confidence that the test has worked well. Obviously, you need to know your controls, otherwise you cannot really interpret it very well. This is the section under investigation. Is a bit sideways. We'll put it the right way up, probably like this. And you noted, Adelina, that there was some pigment. I wonder whether this is the pigment.
Yeah.
Yeah.
It looks like, and it has some sort of more grayish hue, or I think there is some difference if you have enough large cells
between this pigment, which is probably melanin, and the DAB pigment, which is the chromogen of the BRAF antibody. So yes, there are some differences, but there are also some clues. So the clues are that the cytoplasm of these cells is hardly ever stained, or maybe there is a veil of staining. And then the granules, as Adelina said, they are brown, but maybe a little bit grayish brown.
Plus probably coarser. You're more likely to see coarser, larger
yes,
granules.
although if we compare this with the control, you realize that it could be granular, this staining.
The staining is granular, it's just finer, and you get...
And sometimes when it stains less intensely, you can see here, you start perceive granules in the cytoplasm.
Corrado and Adelina, there is a comment that one of our participants has seen places where there is a reaction to BRAF, he wonders, and no pigment according to the H&E. Maybe
according to the H&E. It is always possible. The BRAF mutation in melanocytic lesions is usually an early change. So you would expect this to be prevalent throughout the lesion. It's not necessarily always the same. And I don't disagree. There may be reaction. Could it be this one here? Reaction where perhaps there is a pattern that may be more... it could raise the possibility of positive reaction.
A way to understand could be to put the slides side by side if the sections are pretty similar.
And we can do that. But my experience, and obviously it's important to make sure that the areas that you feel are melanin pigment rather than true BRAF reaction are actually there on the slide, but at different levels, some cells can appear with melanin or without. So it cannot be necessarily a superimposed thing. The other thing is that although theoretically speaking, there should be no there should be no staining developing here unless there is an antibody. You need to understand that this slide has gone through a chromogenic development. And we know that there can be entrapment and development of staining. And melanin is a famous one to do that. It's a big macromolecule. And you could see pigment when pigment is not present on H&E. So don't be always 100% reliable on that. And instead use your morphological acumen to understand whether something is real or not. So for instance, this big emphasis to almost membrane staining with clear cytoplasmic staining, this is not a typical BRAF localization. BRAF is a cytoplasmic localization. So that's a bit unusual. Plus the quality of this staining is not quite right. So Emilia, in response to the comment, there may be one or two cells staining. I don't dispute it, and it would be interesting later on to ask somebody to encircle the region of interest so we can actually discuss it face to face about this. But again, what would be the value of a few cells staining for BRAF in the context of wanting to treat with a BRAF inhibitor, and the data is there only for tumors that have high prevalence. Remember that most of the data acquired was using sequencing of PCR. They have a threshold that means less than 5% prevalence. I'm telling you everything is negative. In any case, maybe even more. So, only if you have an antibody, you could pick up a little subclone that is not representative of the lesion. So, I mean, I feel with confidence that if this was a BRAF test for therapy reason, I would report this as no evidence of BRAF mutation. There may be areas where you see a very fine staining. This is not entirely in focus, but we are very, very high power. And again, at most, this could say it's indeterminate. But again, I feel this is mostly melanin.
Yeah, and I think that your comment on that this is usually a very early mutation, so we should see it more as a general staining is important information to take into consideration. But I also think it relates, well, we could perhaps also now discuss, there was a comment already in the circulation of why using DAB instead of red for melanocytic lesions, as well as if you have tried the melanin bleaching before staining. So comment on that.
Yes. So why brown instead of red? In fact, actually, we do also red. And you are entirely in the hand of your technicians what you get out of your request. Although sometimes, you do specify and say, I want to see red chromogen. Don't think that just because you use the red chromogen, you're going to stop melanin staining as if it was chromogen.
We still see overlapping.
Yeah, so that's a danger. And again, my comment about the fact that melanin is really actually a large conglomerate of different macromolecules, and entrapment is possible. They have their own enzymatic activity as well. So be wary of these issues. So actually, the second comment is much more interesting. Why don't we use bleaching? Yeah. Do we have do we have this nice thing with bleaching? Well, we will show you a case where we can do bleaching, and actually can share with you the bleaching protocol, because to me, this would be almost a standard reference. If you are working on melanocytic lesion, you bleach before any immuno. And we have a protocol where you can actually bleach essentially on the immunostainer. So it's quite easy. Most of the time it works very well because it's designed for low to medium amount of melanocytic staining. When you have heavy macrophage presence, sometimes you have to bleach twice to get to the stage where there is really not enough, not too much pigment to influence your staining. So in summary to this discussion, I would say yes, you can use red chromogen. You need to recalibrate your assessment to red chromogen, which has a different staining intensity. But if you see that melanin disturbs too much your interpretation, actually bleaching is a much, much better option. That again needs to be used carefully, because it may require longer or repeated bleaching cycles, depending on how much melanin there is. Okay, so how do we manage this case? Because if we go back to our PowerPoint, which should be here, there are some people said negative, some people said mutation is present. I think hands on heart, these 25% of pathologists that thought mutation is present, I think this is probably mostly melanin staining. And even if there is a minor population, as we discussed, of cells that potentially may have genuine staining, that's possibly is not very important for oncological reasons. So a few people said mutation, not so sure, I would reflex. But and because we are talking about the treatment decision, even when I make up a diagnosis of no B600E mutation present, well, that's kind of, in broadly speaking terms, 90% of BRAF mutated melanoma are B600E. but 10% are not. So I still have an obligation to look at doing a sequencing or PCR job to exclude the rarer mutations.
Especially V600, yeah.
Especially in position V600, because if you remember from our training, that's where the activating tyrosine kinase mutations are in V600 position that result in a monomer being active. You remember there was the type 1 mutations, type 2 mutations, type 3 mutations, and that the other ones need dimerization, and therefore the therapeutic manipulation requires different handling. Okay, so I think this is first case. Again, as before, as usual, just unmute yourself and make, if you have some comments or some questions, unmute yourself. We go to slide number 2.
Okay. This one, do we need to say anything? 100%.
It's 100%. Okay. So just as a matter of comparison with the first one, would it not be good to see? Okay, which case
I'm
is that?
joking with.
Okay, okay.
We should look
Which
at
case is that?
number 8.
Okay.
So this.
Fantastic. Okay, that's a shallow lesion.
Yeah. So a lot of atypical nesting, vegetory spread, single cell.
Could this be, there are some retraction artifacts. Could this be a Spitz?
I think it's the cells are too different between themselves, and let's say if it would be
huge amount of single cell ascent, although sometimes you can tolerate in Spitz, and then there is definitely a dermal component.
And then you have spread single cells by a long length, a long shoulder.
Yeah, so it's a very ill-defined lesion. Okay.
Let's have a look. I think there's also a little bit of pigment, but let's have quite a lot of color.
Okay.
Okay, so I think this kind of staining, I think in this area, is the one we would like to see always, but oftentimes.
So do you see this? This is kind of interesting. This is almost a HER2 staining or kind of type of thing, but there is clear on nucleus. And when you have melanin, quite heavy melanin pigmentation also in macrophages, for some reason the nucleus appears pigmented, or you seem to have a picture where you have a nuclear blob of brown staining. But actually, when you look at the cytoplasm on the H&E, the cytoplasm of the cells with melanin, they have this very dense melanin body, which on immunostaining makes you feel, oh, there is nuclear staining. But in fact, it's not nuclear staining, it's a dense cytoplasmic staining, probably macrophages. Okay, so this is very nice. You can see also granular cytoplasmic staining, various blobs of various intensity and various sizes. You know, that's a good pattern. Contrast with the keratinocytes that don't stain, you know, that's also good. And then also obviously contrast with the stromal cells. And it's not the first time that BRAF points me towards a vascular invasion that I had not noticed on the H&E. Not particularly on this section, but obviously these cells stand out quite a lot. And, you know, then perhaps you identify something you missed on the H&E.
Another thing is to look at the whole lesion, because sometimes we have two components. We can have two components of BRAF mutated, or the in situ versus the invasive, the dermal component.
Yes. So again, for diagnostic reasons or purposes, you will assess all these compartments. For therapy selection, obviously you need to concentrate on the invasive melanoma. I don't recall having a melanoma where there is this dichotomy between
within the melanoma component, but we need to consider the pre-existing nevus or
very good. And I don't know whether in the circulation there is an example of a misdirection where a benign lesion is BRAF positive, and we can see if there is, but do be careful. Look at it carefully, because sometimes there is a coexisting intradermal nevus. 60% of them carry BRAF mutation. They shine like a lighthouse, and then it's very easy to say, oh, this melanoma is BRAF positive. But then if you look at the tumor cells themselves, actually they may or may not be positive, may be negative.
And that would be the pitfall to go straight for molecular in a lesion that has
big pitfall of NGS, you know. Absolutely, you know, that the NGS would be dead in the water. He will just tell you there is a mutation there, and you would not know anyway.
I
Okay.
do have some slides with a mixed melanocytic lesion.
You want to, shall we show them? You tell
maybe
me
at the end if we have no, like slides, PowerPoint slides.
PowerPoint slides, yes, you can show that again. Okay, so next.
Should we go to next?
Next, yeah. Number 3. So this one is again an easy case. Will be mutation absent, everybody agreed. And again, as we discussed, a diagnosis or no V600E present not in the diagnostic setting, but in the oncological setting, needs to be reflexed to sequencing of PCR to exclude other mutations. So this case is number 13. 13 would be, yeah. Yes. We are enjoying the sunshine of Dorset, which is in our eyes. Okay, big lesion, rather nasty looking, a bit spindly. Quite deep. So, you know, if you live, it depends where you live in the world, but there are now recommendations where if you have a PT3A, minimum PT3A cutaneous melanoma, you have to reflex to BRAF studies immediately. Some places they reflex at a PT2 stage. We are always very special, so we do it on any melanoma that even if it's PT1A and so on, because it's interesting and we want to learn. Some of this is very nevoid. You see the contrast within this more epithelioid and this more nevoid
that's
component.
Quite spindly.
Yeah.
I mean, looking at it, you would expect to have a different, maybe, kind of molecular
pattern, but I think everybody said that this is diffusely negative, and so is the case. How do we know it worked? That's a good question. So we know the reaction worked because of the on-slide control. How do we know the tissue has preserved antigenicity? And then we are in the hands of gods, I think. Yeah.
Yeah, I think so.
But this would have been reflex. Do we have a result for the reflex?
It's possible that we have it in the reports here. Give me a chance.
It's negative.
Thank you, Sarah. So this was
NRAS as well.
Yeah, and negative for any BRAF.
Yeah. So we usually, in these circumstances, we do BRAF and NRAS because, as you know, NRAS is the second most prevalent mutation in cutaneous melanomas. Currently not actionable, but that means I found a driver. Maybe I don't need to look any further, but if I don't find a driver, maybe there is a call for doing more sequencing studies because there may be a driver which is not a common driver. Let's pretend NTRK mutation, KIT, which could be actionable, you know. And so again, in patients with such a melanoma, which is stage, well, I don't know what stage it is, but it's at least PT3 or PT4, then it could be a valuable piece of information for these patients. Okay, so no trouble with this case, I think.
Absolutely not.
Case 4, I think case 4 is probably colorectal. Maybe not. Okay, so here, kind of a bit of a split. The panel decided this indeterminate.
But not 100%.
But not 100%. Okay, so there is a split in the panel. Some people thought this is reportable, but we don't know how. And some people no, we really need another type of analysis. So this is case 17. That's 17, very good. And this is the H&E. This is
not colorectal.
This is not colorectal. This is lentiginous melanocytic proliferation.
Very pigmented.
Very pigmented,
Of
very small.
Single cells or maybe small nests as well.
Yeah. Plump, very plump cells, quite atypical. These are very worrying cytological features, all these bites in the nucleus, etc., etc. Okay.
So was this BRAF performed for diagnostic?
I fear so, because there is not even an invasive component, or if there is single cells. So this is what, this would be a BRAF. Oh, this is a nice case. So do you see this? This is all pigment.
It must be, but there's so few tumor cells that
But do
I'm
you
a
see?
bit worried. Oh, just a moment.
And do
There
you
is
see there is something here in the
Mm.
dermis, or maybe not still?
maybe it's one of those nests that is retracted.
Yeah.
Could this be different color than
This could be positive there.
I think?
Yeah. So you
Could
see
be.
there is this difference. So these cells here, these look to me keratinocytes
Yeah,
with pigment. You know, that's what they do.
there's a lot of
But this
basal.
one, you're right. This looks melanocytic, and this is granular cytoplasmic staining that we like to see. You see the difference actually side by side. The difference is quite notable. Okay, let's see if we
There's
can
more.
investigate further. See, every now and again you find a little pocket that is different.
But then I would expect more melanocytic cells still. I mean, I understand there's not too many of them.
Okay, so maybe we should have put in here also a melanate just to see. And maybe we should have done something in red or with bleaching. I don't know if we have a bleach section of these. Again, you have a feeling that some of these cells may be lesional
Be
cells.
trapedermal as well. Those two cells.
These ones here.
Yeah. But we don't see the full section.
This is kind of difficult. Okay, so this is a kind of interesting but tricky case. I think this would have been done for diagnostic purposes, and so the interpretation would have been different. Not so sure that this is not a macrophage.
Yeah.
But these are clearly, to me, these are clearly all keratinocytes.
Yeah, and we can even see the halo. The other thing in dermatopathology, the difference from in which the cytoplasm is retracted or not. In keratinocytes, you see a halo around the nucleus.
You can just see.
While in melanocytic cells, the retraction is around the cytoplasm. So you can tell that even on immunohistochemistry. Not in all cells, of course, but you get an idea when you identify, oh, this is a keratinocyte. This is probably here
so
as
interesting case.
What would
Should
you
we
do?
need to reflex? I think it's diagnostic. It depends very much how important this is. I guess this was probably in the pursuit of a purist diagnosis because it's all intraepidermal. I think these things are positive.
I think you had a bleached section over there in the folder.
Yeah, there's another section.
Fantastic. Thank you, Simona. Okay, that's great. Okay, so here now.
Oh, but we see more cells.
We see the cells, and the cells are staining. These are the melanocytic cells. These are our target. Okay. So if anybody is interested, I'm sure lots of people will be interested in the bleaching protocol, just write to us, and Sarah or Hannah will let you know what we do. But this is a nice demonstration.
I think molecular in this case would have been a bit difficult. I don't know.
Tell me.
Do you think it's all specific here?
Okay. Okay. Again, okay, Ada, what would you do if this was in fact not an in situ melanoma? These were invasive cells. The patient has metastatic disease. They want to know from you, can we treat it or not? How confident would you be with these results?
With this, I don't think this is, I would have retried bleaching, for instance. I don't think this is our best result.
Not our finest hour.
But
So you
that
would,
being said, I don't think I've seen an invasive melanoma that is melanoma,
yeah,
rather than a special kind of category like PEM
Okay.
or other things that has so much pigment in the way that I would need for an invasive
so
melanoma to
much
do.
bleaching. Yeah. But would you be happy to, if this was an oncological sample and this was not intraepidermal, these were, you know, invasive melanoma cells, would you be happy to say BRAF mutated?
On strictly this one.
Mm.
I wouldn't, I mean, I'm not 100% happy with the staining.
Okay, so you
But
would say
I would
want
definitely
confirmation.
would
I
have
want
had
confirmation.
more.
Okay, and I think this is a good message. I think the message is these antibodies for diagnostic purposes, you need to report when you are 100% confident that that is the diagnosis. The moment you have some doubts, you have a reflex test, use it. Okay, can
And
I
then
ask
we
you?
would have been able to apply molecular here. I would be, okay, we have a lot of very few tumor cells,
Very
and
few
I don't
tumor
know
cells.
how well it would.
You could
yeah.
enrich if you want, you know, do some microdissection and enrich. Okay, can I ask you something? What happens if the molecular comes out unreadable, indeterminate, too little signal, unsure? What would you do?
Well, for this kind of lesion,
Yeah.
it wouldn't matter. But if I had
If this was-
invasive,
if this
you know,
was
I could
invasive.
retry or do a different method, use
Yeah.
a different
So-
testing method.
Yes, and if that testing fails,
If I have two testing methods failing, well, I would
and
just have
you
to say
still have
it's indeterminate.
evidence of this antibody only, and no more possibility of biopsy in the patient. So
Well,
this is where you take this slide to your oncologist and show them and say, this is what happened. You know, if they were
I
talking,
wish.
if they were talking to me, I would say, I am very confident that this signal is specific. I tried to substantiate with another test, but hasn't worked out. I am happy to sign a report to say these cells are BRAF mutated. That means I enable you to use your targeted therapy if you feel this is what you want to do. So I would be proactive in discussing this case with the oncologist and perhaps decide together to put him in a position to use this therapy if necessary. This is all hypothetical.
It's just in real life, usually, I think there's that indication for when, even if you have BRAF targetable, so the oncological indications can be very different from what we write in the report and recommend and say the patient is probably eligible for, because for instance, if you have limited metastatic disease, or they might just try immunotherapy without a second line BRAF targeted therapy. So normally we should have, let's say, a significant amount of disease if we're thinking about.
I just wanted to
with
put
BRAF.
these things side by side to you, just to show you how much better it is life after bleaching. And there you are. Oops, sorry.
Yeah,
I'm a bit
like you
rubbish
say,
with
I
this
would like to see a
computer.
melanate to see how it compares the staining with the.
But you see how much easier
Yeah,
and much better it is to interpret this.
but this section is actually nicer than
Yeah.
the other. I think the one we were looking at.
Yes, this is a bit more,
Maybe.
better scanned. Cool. Okay, nice case. So we go back to next case, number 5. Okay, this is slightly controversial. Panel thoughts mutation absence, majority thoughts mutation absence, a few thoughts we should reflex. I fear this is not a melanoma case.
Maybe
19.
finally 19.
See. Single. So of course it's an endoscopic biopsy. There's kind of lots of vessels, but then high grade differentiated clusters. There's tumor everywhere. Most of it is necrotic. This will be difficult to interpret sometimes, this necrotic tissue. It's a squamous epithelium. What's happening here?
I guess it would be fully differentiated. I don't know, hopefully.
Why squamous?
Well, maybe we're in the
anorectal,
esophagus, anorectum.
Okay, we kind of don't know what's the primary diagnosis. That's obviously a very good, could even be a melanoma. Okay. Let's see the BRAF. Not a piece of signal anywhere. Yeah. Okay, so that's fine. If you want to know for sure, you need to reflex and exclude other mutations. A little bit of signal here. What is it? Nuclear staining. This is not specific, not specific staining. But yes, in general, it's quite clean. There's a piece of brown. This is all extracellular rubbish, not to be worried about. Yeah. Again, with these antibodies, we are really looking at a lot of reaction. You can see here there are tiny little dots.
Do we think that maybe those dots make people think that we need to, or just for other mutations?
Well, there is a little bit of staining here and there, or maybe, yeah, I'm not entirely sure the reason why. Maybe we need to phrase the questions a bit differently to understand, but clearly negative, yeah. Good. Okay. Let's have a look at another one. Again, this is quite a contrast, no?
Yeah.
So case 20. Piece of tissue. Even I can make a diagnosis here. Okay. It looks a piece of bowel, and there is a nasty polydifferentiated tumor lurking here. Something is wrong with processing and fixation. There are all these black nuclei. Don't know why.
Maybe MMR deficient BRAF positive in the past life.
Maybe. And
this is
a nice
gorgeous.
Contrast. Yeah.
Gorgeous staining.
Yeah.
And we see the quality very well. That granular, not too coarse granules. Then we have aggregates of staining, but is.
Yeah, so that's a kind of a typical staining pattern where you can be reassured that there is mutation.
I think we can show them also we can have background like in the normal mucosa or in the muscle tissue.
So clearly this is not specific staining. You know, most of the time you're hitting the nucleus and then you're staining this apical mucinous rich region of the cell. It may be genuine, who knows, but often we feel this is, you know, definitely the nuclear staining is not appropriate. Is there another bit of normal mucosa? Okay, so this is a little bit better, and you see the contrast again. Sometimes you can see a little bit of staining.
And I think we have muscularis propria and because we have the whole bowel thickness.
So this one again is a bit non-specific. And I think we discussed this in the training session. There may be a degree of staining in the smooth muscle, and you can see here how well defined it is. Now you're in subserosa, which is negative. But this is, I wouldn't say this is specific. You know, it's okay to see it. This is probably again part of not ideal pre-analytics, fixation, processing, etc. But if you know that this occurs, you're not going to be thrown out of sync for interpretation. This is a smooth muscle of a blood vessel. Okay, so that's nice case. So if this is BRAF positive, there's a lot of important reflex to BRAF positive. You were talking about mismatch repair, whether this was deficient or proficient. So it is very unlikely that a mismatch repair deficient tumor, BRAF positive, is in the setting of syndrome like Lynch or otherwise. But also BRAF is a prognostic indicator. So the combination of mismatch repair and BRAF, positive, negative, or otherwise, define 4 categories, and each has got different, if you want, association with prognosis. So that could be an important triage antibody to, you know, in addition to tumor stage, grade, et cetera.
And how we're doing with BRAF inhibition in colorectal?
BRAF inhibition colorectal is better because they learned that they need to block also MEK. So it's quite, it's more successful. At the beginning, it was really nobody was making any progress. But, you know, more recently, patients have been treated in combination with other immunotherapy or other therapy using BRAF inhibitors. And so they are beginning to create better second-line treatment for these patients. So it's worthwhile knowing. Also, BRAF V600E is a mechanism of escape of cetuximab, or anyway, any anti-EGFR antibodies that are usually given in combination to these patients. So if you flag up BRAF mutation, it means that they can use cetuximab, but they need to give tyrosine kinase inhibitor to inhibit the downstream signaling of this tumor.